is Dr. Samir Bashey, and I'm a board-certified dermatologist in Los Angeles and New York City. And welcome to part 2 on the VO anti-aging protocols in practice. And again, if you want to follow me on Instagram, my hashtag is @DrBashey. Part 1, we talked a lot about the different products, the different ingredients, protocols. We went through a number of clinical case scenarios of how to utilize these products, how to put them together, and how to successfully treat a number of patients. We also talked a lot about the science, the basic science, really the microscopic and the macroscopic data behind all of the products and behind how we use them. Now we're going to talk a little bit about something that's much more clinically applicable, much more practical, and put it together in terms of, okay, what procedures can I do? What procedures do we have here at VO that we can utilize to the best ability to improve patients? So first thing we want to talk about is we have a very, very long and deep relationship with the chemical peel. And Dr. Obagi, this starts with Dr. Obagi, and Dr. Obagi, in my opinion, is the father of the chemical peel. In the field of dermatology and aesthetic medicine, we can go back several thousands of years, and we've seen that the chemical peel has been utilized by the ancient Egyptians, by the ancient Indians for cosmetic purposes. But for a long time, we didn't understand chemical peels. We had no idea how they really work. People tried to define them. People tried to make sense of them a little bit. But Dr. Obagi, for the last 40 years, in my opinion, and regarded by every major dermatologist in the community, has spent a significant amount of his time formulating and mastering the science of the chemical peel. And this background, you can see, is demonstrated in a lot of what we have here at VO. Dr. Obagi has several firsts with the chemical peel. He demonstrated the safety of PCA. He decelerated the peeling process. He established death signs. He controlled a volumetric application with a code system. He configured a dermal stimulation model with epidermal peels. He was the first one to figure out that you can add a dye to a peel safely. We have a strong, long history with chemical peels. And me, myself, I have had the privilege of working side by side with Dr. Obagi in his Beverly Hills office for 3.5 years. And during this time, I would say I was able to learn from him one-on-one how to do chemical peels, superficial, medium, depth, and deep chemical peels. So I don't regard myself as an authority the way Dr. Obagi is an authority on the subject. But I have had the privilege of spending a significant amount of time with him and really learning to see how he understands the peel, how he thinks about the peel, how he combines the peel with skincare and with products. And so, I have this privilege of being able to really impart a lot of the knowledge that I've learned from him to everyone that's watching this webinar. And I have to really thank him for teaching me all of this and really being a mentor to me. One of the things that I have to say is that Dr. Obagi is very, very gracious and very generous with his knowledge, which is not very common. And I myself would like to be generous with the knowledge he has given me so that this can be very, very valuable to everyone that's watching and that you can translate this immediately to be used on your patients. Now, we have to understand, in today's age, we have lasers, we have microneedling, we have radiofrequency needling, we have things like Ulthera, we have all these different modalities, right? We have surgical modalities, facelifts, and things like that. But if you really step back and you look at it, the chemical peel is the most affordable form of resurfacing that we have today, right? A CO2 laser is going to cost several $100,000. Some of the ones, price is close to $200,000, and some of the cheaper ones between $60,000 and $200,000. But it's a lot of investment up front, right? Chemical peel is just based on your experience, picking the right candidate, and really performing a procedure. The actual cost of the chemical peel is very, very affordable. It's very efficient. We can use it for a lot of different things, right? The VO chemical peels that we have are a vital, really vital supplement to the skincare protocols that you're going to put your patients on, and we can treat a plethora of skin conditions with it. We can treat acne, rosacea, melasma, PIH, laxity, texture damage. And all of the peels that we have at Zeo, and this is what I want to stress, these peels have been modified, tested, through years of experience, put together in a safe way. And when it comes to chemical peels, you want to control the safety of the procedure, right? You want to control the type of peel you're doing, who you're doing it on, the volume of the peel. And I have to say that once you start peeling with Zeo Skin Health, it is virtually impossible to go to another peel or another peeling company, or just take the product, the regular peels, and just do them yourself. And that's because the safety margin that we have created here cannot be replicated with any other peel company commercial, or just buying the product, let's say 10% or 20% or 30% DCA and just doing it yourself. The safety that we have created here is just unbelievable. I have a lot of experience doing chemical peels, and till this day, I will never do a chemical peel that's not Zeo based, because I know I can get the consistency of my results, and more importantly, the safety for my patients when I do it in this way. And I'm going to teach you how I do the chemical peels, and basically this translates to how Dr. Obagi has done his chemical peel. And I have to tell you, in terms of efficacy, safety, affordability, you can't beat our peels. Now, when we think of chemical peels, we have to think about what we're treating. So we're primarily treating the dermis and the epidermis. We're treating really mostly the upper part of the dermis, and we're treating the majority of the epidermis. When we use the ingredients, we have to think about the safety. And we talked about safety, right? It's a huge emphasis on the chemical peel. Safety with chemical peels not only comes with the volume of the acid that you're going to use, but your decision to use certain ingredients versus others. My opinion, as well as what has been demonstrated by the literature and what is taught to me by Dr. Obagi, safety in chemical peels comes from utilizing ingredients like retinol, salicylic acid, TCA, lactic acid, things like that. Where you get into less reliability, kind of danger zone, less efficacious peels, glycolic acid, phenol, croton oil, these things have a poor safety profile. Higher level TCA, meaning above 30%, has a poor safety profile. So when it comes to the agents that you're going to pick, you want things that have death signs, reactions in the skin that you can see, and moreover, things that have been tested over the course of time that have established safety, right? That, to me, is more important than utilizing ingredients that can go very, very deep, and that might work, really, really well in 1 out of every 3 patients, but 2 out of your other 3 patients get scars from it. That's not what we want. We want reproducible, safe forms of resurfacing the skin. Now, when you think about the chemical peel, we have to think about it not in a vacuum, right? And that's what we're talking about here. The skin health science becomes full circle. The peel is not something that is just done by itself. The peel is part of your role as both a clinician and an artist, right? People are seldom coming in with one problem, right? The peel addresses one facet. We can create tightening, we can improve epidermal and dermal issues, right? But it's about how you combine your peels with ablative or non-ablative lasers, your neurotoxins, surgical treatments, volume depletion issues like with using Sculptra or fillers. It's about how you put everything together. And that's really what this is all about, right? It's not just about doing a peel in isolation. It's about looking at your patient as a whole, and you have the palette, and you're the artist, and you say, okay, the cream, that's my backbone. The chemical peel, I'm going to do this to address this problem. And then I'm going to utilize these other issues. That's how you create a satisfied patient that gets an outstanding result. Everything is taken together. It's about comprehensive treatment, and it's about combination therapy. So we have 3 basic peels in the Zeo armor. Now, there's modifications to these and things that you can do, but I want to speak to basically the three basic things that we have. The modification of these things gets into when you have a lot of experience doing them and you're more comfortable peeling. The first thing we have is the stimulator peel, the VO stimulator peel. We'll talk about that. This is basically utilizing, advanced radical night repair in a certain fashion for a certain period of time. And we can create light exfoliation and texture improvement. And that's a self-administered peel, meaning patients do it at home. You instruct them how to do it, and they do it at home. The VO three-step peel is a more aggressive peel. We're talking about primarily an epidermal peel with dermal stimulation, right? And then we have the VO controlled depth peel. That's the maximum level peel that we have, and you can adjust it to certain different depths. However, we're going to get the maximum amount of tightening, improvement in both epidermal and dermal issues with this peel. Now, one thing that I should tell you is, and we'll get to this later, is I personally never perform a peel of any kind without prepping my patients first. And I don't mean mentally preparing them. Of course, we talk to them about what to expect, right? I mean physically preparing them by putting them on protocol. So you want to get the most bang for your buck out of a peel, your patient must be adequately prepared for the chemical peel. That allows the skin to be primed, to take the ingredients well, to respond better, and to recover faster. So let's start off with the VO retinol stimulation peel. Again, this is an at-home peel. We get accelerated exfoliation of the epidermis, and we get stimulation of the epidermis. And we talked extensively about this product in the last webinar. This is 1% retinol that we have in a very, very technologically advanced delivery mechanism. So we get a lot of this product into the skin. Now, again, use this product by itself, you're going to get improvement. Use this product with a skincare program that's designed to treat a certain condition, you're going to get maximum improvement. And the benefit of this is you can get people introduced to the concept of peeling without them undergoing a procedure. So it opens them up more in the future to potentially having one of the more advanced peels that we offer. Now, there's really a few ways that this can be done. I'm going to tell you the way I do it, okay? I put somebody on a protocol 4 to 6 weeks. So they're comfortable with the VO products, they like them, they know how to use GSR, we've identified a problem that we're trying to treat, and we use this as an augmentation course. During the time that I have them peel, I decide along with them, do they want to peel for 3 days or do they want to peel for 5 days? That's the first decision in this algorithm that needs to be made. You want a 3-day course or a 5-day course? Now, the next decision in this algorithm is, do you want easy mode, normal mode, or hard? The harder you do this peel, the longer you do this peel, the more, quote, downtime you'll have, but the better the result. So the hardest of the hard mode is going to be the 5-day course at hard mode, 10 to 12 pumps twice a day. The easiest of the easy is going to be the 3-day course with 5 pumps just twice a day. So you have to talk to your patient. You have to determine how this fits into their protocol, how bad their skin condition is, and come up with a program that works. It might be a good idea to start people on an easy, normal 3-day course first, and then move on to the harder courses later on as they get more accustomed to it, because you can peel quite a bit, right? Also, you're going to make a decision. If someone has thicker skin, or they're a man, or their skin's very oily, you may want to kind of go on the more aggressive courses because you want to see more of a result, right? So the 3-day course, easy mode is 5 pumps morning, evening. Normal is 8 pumps morning, evening. Hard is 10 to 12 pumps morning, evening. 5-day course, easy 5 pumps morning, evening, 8 pumps morning, evening for normal, and 10 to 12 pumps morning, evening for hard, right? During the time that they're doing the peel, I only have them using really 3 products. I suspend all of their protocol, other than their face wash, the renewal cream, and the actual advanced radical night repair. So I have them stop everything else, including sunscreen, because I have patients stay indoors while they're doing it. Now, some people will augment sunscreen and put sunscreen in this as well, but me personally, I don't, because I want them to get maximum results of this peel. And again, they're putting on retinol in the morning and in the evening, so we don't want them to get, any extra sun sensitivity by applying that retinol in the morning. We can get a significant amount of improvement by just doing the stimulation peel. And again, we look at this patient, right? She's on a protocol. There's no question, right? I put all my patients who get peels on protocols. We identify her problems initially. We see a lot of volume loss. We see the sunken eye area, the sunken temple, little sun damage and uneven tone. We add a basic protocol that's anti-aging, like we talked about in the last webinar, plus we add the stimulation peel. We get a lot of change. And this was a normal stimulation peel. This is a 3-day stimulation peel. So coupled with your good skincare, we can create quite a bit of change with just this protocol alone. Now, we have another patient here, and if we look at her skin, she's got some rosacea, she's got sun damage, she's got some loss of volume, and she's got a little bit, I would say, she's got some enlarged pores on the nose, we could see. In her after picture, we put her on an anti-aging protocol that addresses some oil, and we put her on the more thicker, stronger 5-day course of the retinol stimulation peel. And the reason I did that is because if you go back to the first picture, we see thicker skin, but we also see oilier skin. If you look at her nose, we see larger pores. So, the smaller, weaker program is not going to be beneficial for her. The stronger program is going to be more beneficial. And we look at her after picture, we can see that she's still irritated a little bit from the peels that we made her do, but we can see all the benefits of the peel along with her skincare program, right? We see thicker skin, improvement in the fine lines, wrinkles, and we see an improvement in the sun damage, as well as improvement around the nasolabial folds and mouth. And again, the reason we see this increased volume is because of increased hydration from the stimulation of the chemical peel. And this redness that she has on the cheeks and the forehead, this is easily going to go away on her own, right? So this is a lady that maybe I would have her do the moisturizer a couple more days and then put her back on her skincare program. Now, let's take some time and let's talk about the 3-step peel and why I really like this. The 3-step peel is a peel that, in my opinion, is very versatile. It's composed of 3 different steps. You have the peel solution, and we'll talk a little bit about what that is. You have the retinol cream complex, and you have the hydrating cream complex. So a very, very simple 3 steps. You apply the peel, apply the retinol, apply the hydrating cream, and we get a lot of improvement. What I like about this peel is that we get a lot of dermal stimulation. So let's go back for a moment. We get a lot of dermal stimulation from an epidermal peel. And that's basically because of the way the ingredients work. The peel solution is composed of a combination of TCA and salicylic acid. We have some other acids that are in there, but in my opinion, I primarily am focusing on the salicylic acid and the TCA, and it's about 10% TCA. There's 8 mLs in there, and most people are going to get the full 8 ml solution. The TCA in there coagulates the epidermal tissue, which then allows step 2, which is the retinol complex, to create dermal stimulation. So essentially what we're doing is we're coagulating the epidermis so that we can get retinol, pure retinol into the dermis, and that pure retinol then stimulates the dermis. Then we lock it all in with the hydrating cream on top. So that's the component. That's how this works. It's a very versatile peel because I use it for uneven tone, I use it for hyperpigmentation, I use it to augment an anti-aging protocol, I use it for fine lines, I use it for PIH, I use it in acne. I mean, it's really, really, really versatile. There's really not a lot of situations where you can't use it. Maybe you wouldn't use it in someone who has very sensitive skin or someone who has uncontrolled rosacea, but this can be done in any skin type. So we're talking skin type 1 all the way to skin type 6. But, like I will tell you, you may hear from different people that prep is not required for this. In my personal practice, I will always prep with the 3-step peel, always, okay? Now, the way this is applied is very important. And I think it takes a little bit of skill to apply this peel. So we're going to go through a little bit about how it's done. If you look at the first picture on the upper part of the PowerPoint, we have poured all 8 ml meaning all the full content of this product in a bowl. A lot of commercially available chemical peels that come in small bottles have 5 mLs in them. However, we have 8 mL. And we encourage people to use the full 8 mL. In rare circumstances, you may not use the full 8 mL. So, for example, if someone has a smaller face or thinner skin, you might use 5 mLs or 6 mLs. But the majority of the people are going to use the full 8 mL. On the bottom picture, we have the patient's skin prep. Now, the preparation of the skin should be, the patient's been on, creams for a protocol for several weeks. I like to do 4 to 6 weeks. And then I have them discontinue any product that has retinol or retin-A in it and the exfoliation accelerator about 3 to 5 days prior to the peel. And that's because you want their skin to be primed, but you don't want their skin to be over primed. I'll pour all 8 mLs of the content into the glass container, and then I will take the cotton pad that comes with it and I will fold it in 2. So I have sort of a quarter circle of a pad. I will then go ahead and wet that quarter circle pad, saturate it, but not to the point that it's dripping. Then I will start applying the peel, which is step 1, the application. When you start applying that mixture to the patient's face, you're going to see a mixture of a frost and a pseudo-frost. At 10% TCA, you really will not see much true TCA frosting in someone's skin because you don't coagulate a huge chunk of that epidermis with 10% of TCA. That's why there is 8 mLs in that is accounted for. So you'll start seeing a true frost towards the end of the procedure. Initially, when you first apply the product, you're going to be seeing the pseudo-frost from the salicylic acid. And then as you continue to apply the product again and again and again, you will see the self-neutralization of the TCA, 10%, in the form of a frost-type powder that accumulates on top of the skin. Now, unlike most TCA peels, when you see a frost, most people say, okay, you stop. However, with this accumulation of the powder, you keep going. You keep going. And the beauty of the TCA that we have in here and the beauty of the combination ingredients we have in here is there is a cofactor in the 3-step peel, in the chemical composition of the bottle and the product, that neutralizes itself upon hydration. So it kind of stops the peel automatically before you hit the dermis. So it auto-regulates itself and it's self-neutralized. So I will take the 8 mLs in normal skin or even thicker skin. I will go through several cycles where I paint the acid on the face with the quarter fold of the circular gauze. And then I will take a Q-tip, as you can see on my right-hand side. I take the Q-tip and I actually apply the solution to the upper and lower eyelids carefully. The upper and lower eyelids can easily tolerate a 10% solution of TCA. How do I know this? Because I'm regularly doing the controlled depth blue peels where I'm applying, 20, 25, 26, 28% TCA on the upper eyelid and lower eyelids to the papillary dermis. People tolerate it just fine. So, apply it carefully with a Q-tip. And if you get any TCA in the eye, you can just flush it out with a saline flush. So again, you're going to apply to the entire face. You're going to feather underneath the neck and behind the ear. And I should mention that this peel is safe to use on the neck. It's safe to use on the forearms. It's safe for any part of the body. Okay? It's completely safe for any part of the body. So you can use it on the neck, the décolleté. It's not a problem. You may need more volume than 8 mLs if you're going to do the face, neck, and chest. So the 8 mLs is going to cover, in my opinion, a normal size face with some degree of blending onto the neck. Once you've exhausted, let's just talk a little bit about pain control, okay? Majority of your patients are not going to need any form of pain control for this procedure. The best thing that I recommend is a Zimmer cooler or a form of forced air cooling or cryogen cooling. That's enough. We'll usually have the patient hold it they won't need it until the first several passes of the product, then they're going to start using it. I don't recommend sedation. I don't recommend any kind of oral sedation or Ambien or anything like that, or anything really, because this is a very tolerable procedure for the vast majority of patients. After you finish the whole 8 mLs with feathering, you're going to apply the retinol cream. There's 2 packages of retinol cream. You're going to apply one entire package to the whole face, and the purpose of that is to get the dermal stimulation. If you only do the first step, you're just going to be coagulating tissue in the epidermis. You will miss out on the advanced technology that we're presenting with this 3-step peel, and that would be the dermal stimulation, right? Ultimately, you want the upper part of the dermis to respond to the chemical peel, build collagen, build elastin, build those glycosaminoglycans, all the things we talked about in the last webinar. So, plus you want to get to a lot of what the melanocytes are, right? And they sit at the dermal epidermal junction. So I will go ahead and apply the retinol complex. Note that even though you're done applying the acid component, you're now applying retinoic acid on the face in the form of retinol. Your patient's going to complain that this part is going to continue to burn. So you're going to want to have that Zimmer cooler still on. That's important. A lot of people who haven't done this procedure figure they're done with the acid application in the bottle. They stop the Zimmer cooler, but you're going to want to have the Zimmer cooler on. I will go ahead and I'll apply this everywhere, including the upper and lower eyelid. Then the last step is you want to seal everything in, you want to hydrate, and you want to cool everything down. So I will apply the hydrating cream to the entire face. And again, it comes with a tube of the hydrating cream. You don't need all of it. You just need enough to cover the face in a nice thin layer. And of course, don't forget the neck if you're placing it on the neck and the upper and lower eyelid. At that point, your patients are a lot more comfortable, they feel better, and usually they stop the Zimmer cooler themselves. Now, this is what the procedure looks like when you're done. You notice that yellowish tinge, that's the acid, salicylic acid, TCA, the coagulation of the tissue and the powder that forms on the skin. And that's something that just, will go away on its own. The aftercare instructions for this are important. I have seen peeling from this from anywhere from 3 days all the way up to about a week, okay? And it just depends on a number of different factors, right? The longer and more aggressively you prep the skin, the more peeling you're gonna get. The thicker and the oilier the skin, the less peeling you're gonna get. The thinner the skin, the more peeling you're gonna get, especially if you utilize a little bit more concentration. So in terms of your procedure, you wanna do it in the right way. Now, I'm going to explain a potential pitfall here as well. I have seen cases, not my own, where I've done this and people have not peeled. And that's because it's common sense. You have someone with thick, oily skin, you're using 10% TCA, which by definition is a superficial peeling agent, and the practitioner has not prepped the skin at all, right? In order for this to work effectively, you need to prep the skin. Another potential pitfall. Your patient calls you, 2-3 days later, they say they're not peeling. The vast majority of patients are going to peel on day 3 or day 4 from this. They're not going to peel on day 1 or day 2. Don't expect them to peel the same day for the first 2 days after. Peeling will start day 3, and then it will commence anywhere from 3 to 5, sometimes as long as 7 days after, just depending on how aggressively you prep them and how you've done the peel, okay? Now, another potential pitfall. Do not take this peel and do 10 layers over one area. Because you're going to get into the dermis, you're going to get an area of delayed healing. Instead, paint the peel evenly on every part of the face, evenly, until the solution has run out. That's important, okay? Further aftercare instructions, suspend all of the ingredients in your protocol until the skin has epithelialized. Right? So there's a couple of things that I want to talk about, and then we're going to go into some before and after pictures. The day after your peel, you'll see that there's another retinol packet in there. Have your patient wash their face in the morning, okay? Don't have your patient wash their face the day of the peel after the peel is done. Instead, have them wash their face with their regular Zeo cleanser the day after. Once their face is dry, they apply the remaining retinol packet. And then, that day and the next couple of days after, all they're going to do is their face wash twice a day and the hydrating cream twice a day or 3 times a day. That's it. They don't do any of the pads. They don't do any of their other products. They just do those 2 things until the skin is epithelialized. And then once the skin is epithelialized, you put them back on the protocol as they were doing the protocol before. That's all. I have not seen herpes breakouts with this peel ever. However, it's something to consider in a high-risk patient. If you want to, you can prophylax with an antiviral medication. Other things are not necessary. You don't need antibiotics. You don't need any of that other stuff prior to this, okay? And just remember, paint everything evenly. Don't do 30 layers over one spot because it's dark. Paint evenly. So we have a patient here, Southeast Asian descent, bad melasma over the lips, forehead, cheeks, bad texture, uneven tone. Put on an aggressive skincare program addressing the pigmentation. We added in, I believe it was 2 3-step peels in her case. We see immense improvement, right? Now, the deeper you go with a peel, and we'll talk about this with the next section when we talk about the controlled depth peel, the more tightening you're going to get. But the deeper you go, the more downtime you have, right? So you may want to combine a series of 3-step peels. However, a series of 3-step peels does not equal 1 deeper peel, physiologically. Here's an example of how we perform the procedure. I have my patient lie flat. I like to have my patients chin up or at a horizontal level with the ground, and I am constantly looking for dripping. Never should you be taking the container with the acid right over the patient's face, neck, or chest. It should always be from the side with the acid taken from behind and applied that way. You don't want drippage. You don't want spillage. You don't want your elbow to accidentally bump the acid onto the patient, okay? Very important. We touched on this before, but I want to touch on it again. Notice the progression. First patient is of Middle Eastern descent. Second patient is of Caucasian descent. Both patients have been prepped. I know immediately when I apply the acid on someone's face, whether they've been well prepped or not prepped, if they're using the product or not using the product. I know that by the level of the coagulation of the epidermis I get, how quickly the polymerization powder is created, and then I know by how they actually peel. If they peel in small little microscopic peel, I know they have not prepped well enough. If they peel in sheets, I know that they've done it more aggressively. So if you notice, day 2, we just see a little darkening of the face, which extends to day 3, and then the majority of the peeling is occurring from day 3 onward. And the peeling can be quite extensive. Okay? I wanted to mention to people that, again, this can be done safely in people of all skin colors, ethnicities, and backgrounds, right? This lady has been prepped. She's been prepped for several weeks prior to doing the peel, and then we perform the peel. You can see the picture on the right-hand side is when we had finished the application of step 1, right? We have not put the retinol complex on, which has a more yellowish hue to it, but we do see polymerization and we see coagulation of the epidermis with the powder of the mixture on. Okay, now step 2, we apply the retinol complex. Again, this is the same in people of all backgrounds and ethnicities. And then finally, we apply the hydrating cream and the procedure is concluded. Another example, Caucasian lady, sun damage. We see a little bit of faint rosacea with some hormonal type acne, a little bit of loss of volume as well. Again, this is 1 3-step peel with an aggressive skincare program. Massive improvement, massive improvement. Okay, another case, very aggressive melasma here. We see loss of volume. We see, in addition, some PIH. We see some degree of rosacea as well, underlying texture damage. We can improve that pigmentation to an immense amount, even with a superficial peel. The reason that we are getting a lot of improvement not expected of a superficial peel is because of that step 2, which is the dermal stimulation. Okay? In concept, thicker, oilier skin, we see a lot of acne, we see some syringomas, we can see melasma, early melasma, PIH, sun-damaged skin. We see a lot of improvement in the texture, tone, color, as well as the melasma with an aggressive skincare program and a 3-step peel. Okay? In concept, melasma, woman of Mediterranean descent, loss of volume loss. Look at the volume loss around the mouth. Aggressive skincare program with a 3-step peel. We have nearly improved all of this woman's melasma with just a superficial peel, right? And the key is the dermal stimulation. That's why we're getting this degree. This cannot be done with a regular TCA straight peel. This cannot be done with a glycolic acid peel or other peels. We're getting the dermal stimulation here, which is why we see this degree of improvement, okay? Same concept, early loss of volume, early melasma on the forehead, and we see some sun damage and some acne rosacea type phenotypes, aggressive skincare program, massive improvement in melasma, improvement in the thickness of the skin, right? Improvement that we can definitely see from a mile away. Same concept, Southeast Asian woman, bad melasma, uneven tone, PIH, thicker, oilier skin, aggressive skincare, 3-step peel, massive improvement, right? Another concept, olive skin tone, Mediterranean descent. We look at our forehead, we see the acne, we see the hormonal acne on the lower face around the mouth, uneven tone, and PIH. 3-step peel in combination with an aggressive skincare program addressing oil, massive improvement. One thing that I should also mention about the 3-step peel before we get into the controlled step peel is the 3-step peel can, I repeat, can be performed while people are taking Accutane, okay? Can, and I do it all the time. Superficial peels in general can be performed with people on Accutane. Deeper peels can, in general, not, okay? Now, the controlled depth peel is a concept that Dr. Bashey really put forth. And the controlled depth peel is a very versatile peel. We can use it to improve age, uneven tone, melasma, sun damage. We can create tightness, improve PIH, reduce fine lines and wrinkles. It can be done, and I have done this. It can be done in every single skin type. And I have peeled a number of skin type 6 people with a controlled depth peel. It's all about the preparation before and after the peel. The controlled depth peel takes TCA and mixes it with a base. And what the base does is the base controls the depth, hence the name, of how fast the TCA gets into the dermis, and the base allows, because of its blue color, acting like a map for you to know where you have applied the TCA. The base is composed of saponin, and the base is mixed with 30% TCA to create a mixture between 20 and 30% that is applied in a coat system several times in order to get to a certain physiological depth sign that can be easily appreciated in patients of all ethnicities and skin colors, okay? Why introduce this peel in the first place? Why not just do straight peel? Well, a little history about TCA. TCA used to be performed in in percentages of 50% or more. And TCA is a clear liquid. So people were applying the peel. They didn't know how much they were applying. The volume wasn't fixed. They were applying this clear liquid and doing multiple applications in an area that they thought they had not done, but they actually had applied. They didn't realize that at 50% TCA, the acid would penetrate way too quickly. And it was impossible to observe depth signs too properly. The peel was too accelerated, it was too fast, right? TCA was being absorbed unevenly in different sides, different parts of the skin where it was thicker and thinner, etc. So this innovative peel by adding the base, reducing the percentage to 30% or less, has increased the efficacy ratio of PCA and decreased the ratio of damage, and has provided a safety margin that can be unparalleled that's not paralleled in any chemical peel that I have seen. The blue base adds visual guidance, the saponin, and creates a system that decelerates the peel, meaning slows it down, so that you can actively observe an endpoint. And that's how we say we control it. If we want to go deeper, we apply several more layers and we observe a depth sign. Or if we want to stop where we are, we stop where we are. So it minimizes the TCA, the complications associated with regular TCA peel. And the blue dye is enriched with saponins and antioxidants that basically control the inflammatory process to begin with. Now, the protocol for this is you need to identify a patient. You need to identify a diagnosis. There needs to be an indication. You need to decide how deep you want to go with the peel. You need to prep the skin. The longer you prep, the safer it is. You need to treat any coexisting disease during this prep. I personally do not recommend the use of Accutane in preparation for a blue peel. I would caution against doing this procedure until you have, stopped Accutane for a minimum of 6 months. However, in theory, this procedure can be done if done to just the level of the dermal epidermal junction with someone on Accutane, but I recommend personally not doing it. You need to treat the coexisting disease, decide if you're going to do HSV simplex prophylaxis, and then you need to, of course, learn how to do the procedure properly, and then you need to take care of post-peel management, right? You can do the procedure perfectly, you can prep the procedure perfectly, but your result's going to be dependent on how well your patient follows post-operative post-operative care. Now, I want to focus on 3 different depths, okay? The first depth is the papillary dermis. This is the area that is immediately underneath the dermal epidermal junction. If you do a peel to this level, you're going for even blue on the skin. You're looking for, behind that even blue, some degree of redness. You want to see the redness underneath the blue. So you're not looking for like a darkish blue color. You're looking for that even light blue, and underneath you're going to see redness. Why you see redness? Because the blood vessels are active, right? The blood vessels are underneath the papillary dermis, and at that point you've not coagulated them, you've not, passed them, so they're flowing. They're flowing normally, which gives the red hue behind the blue. And you're going to look for epidermal sliding. The epidermal sliding indicates that the juncture, the DEJ, the dermal epidermal juncture is intact, meaning the epidermis and dermis still have maintained their ties. When you go to the level underneath the papillary dermis, you are now at their location called immediate reticular dermis, known as the IRD. During this period, you have now lost epidermal sliding, you've lost the redness, you've crossed those blood vessels, so you're looking at even blue. And when you get to a more advanced level, you can customize your peel, what we call a design-controlled depth peel, where portions of the peel can be different things. So where you have more sun damage, more wrinkles, you may decide in that particular area you want to go to the upper reticular dermis. That's the area immediately below the immediate reticular dermis. You will have lost the epidermal sliding. You will have lost the redness behind the blue. Instead, you will see a light gray tone to that darker blue. That's how you know where you are. In general, I recommend that for the majority of patients, nearly 80 to 90% of problems can be fixed by just going to the papillary dermis or the IRD. It is really not necessary to go to the upper reticular dermis unless you are a very advanced peeler like Dr. Bashey. Okay? Now, to understand the levels, basically you just have to understand anatomy, right? Papillary dermis is the first level we get to where we create a medium depth peel. The next levels in the medium depth peel are the IRD and the URD. As I mentioned before, you're seldom, if ever, going to take an entire face to the level of the URD. The URD is primarily designed to be done focally in an immediate reticular dermis level controlled depth peel, okay? Usually that's going to be in trouble areas, and that's primarily areas like around the mouth and places like that. That's what we call a design peel, meaning you create the peel at multiple different levels. As I mentioned before, I will never, even in a Caucasian, even in anyone who's had this before, who comes to me and tells me, oh, well, I've had many of these before, I will never do this procedure without prepping the skin. In a Caucasian, 4 weeks minimally. In a non-Caucasian, 6 weeks minimally. Notice I've used the word minimally. The longer you use the prep, the more stable the skin is prior to the peel. Why prep anyway? Well, you prep because you restore a strong barrier function. You activate the cell's response mechanism. You hydrate the skin better. You treat existing disease so that you don't get a complication. And in general, the skin is primed to receive TCA. Everything is even. You don't get an area where you overtreat with the TCA, right? That will reduce your complication rate immensely. Now, we've already done a ton of stuff here to reduce your complication by fixing the volume, adding the blue base, adding antioxidants to the blue base, so on and so forth. But a further step to prevent additional complications is the preparation. Now, in practice, I will give every patient who takes this peel HSV prophylaxis, without a doubt, without any doubt. When they tell me, I'll put them on Valtrex 500 swipes a day. If I suspect the patient has had a history, if they tell me they've had recurrent fever blisters, then I'll put them on Valtrex a gram twice a day, prior and then during the healing period. Okay? How do we prep the skin? I'll use Refisa 4 to 6 weeks, as I mentioned before. I will use GSR. I will use exfoliation accelerator. And in the right patients, I will use the pigment control blending and brightening creams as I need to. I may definitely add the vitamin C and the daily power defense. And because I want to control the anti-inflammatory response prior, during, and after. I will also treat existing disease, right? So if the patient has a lot of acne, I'll put them on sulfur mask, or I will add spot treatment with the acne control cream. I might go more vigorous. I might add something oral like doxycycline, whatever it may be. I need to control active disease first prior to performing this. But you need to treat topically and prep prior, and that's really, really important. I can't underemphasize this enough. Okay? How do you know when your conditioning is complete? Well, I've given a general framework, 4 to 6 weeks, right? But that's a framework. Some people are going to be after that. Some people are going to be before that. In general, when active disease is under control and sensitivity is eliminated and patients are able to tolerate the program you put them on that has the Retin-A in it, the Refisa in it, then you know you're ready to go. The longer conditioning, 6 weeks plus, is something I use for in the Obagi skincare classification under Dr. Obagi. For people with deviated or darker or complex skin tones, meaning people of Mediterranean descent, Southeast Asian descent, Indonesian, Indian descent, I'll put them on a longer preparation time in order to minimize any potential issues that I may have. Okay? Hydration with the product creates predictable frosting from the TCA. GSR with the salicylic acid creates even penetration of the peel everywhere. Utilizing the Refisa and the brightening and blending cream stabilizes the melanocytes, so it controls my PIH. And utilizing the antioxidants and vitamin C and daily power defense improves the barrier, which is something we spent a lot of time on in the first webinar. And again, that strong barrier prevents infection risk in the aftercare period. Okay? I want to give people an idea of where we are. Again, if you look here schematically, the stratum corneum up to the basal layer is that's the epidermis, and we get into different parts of the dermis. Again, what this represents microscopically, we are not 700, 800, 900, 1,000 microns into the skin, okay? We are basically, depending on how thick or thin the skin is, a few hundred microns in. That's the depth of our peel. We're not going several millimeters deep. That's not possible. We're trying to stay in the papillary dermis, the IRD, or the upper reticular dermis, right, which is a few hundred microns in. We're not trying to go very, very, very deep here. Okay, let's talk a little bit about performing this peel. A lot of this performance of the chemical peel is going to be based on experience. I highly encourage that you spend time learning this. It's sometimes difficult to appreciate watching someone else do it. You have to do them yourself, and you start slow by doing the lighter peels, and then you gradually, as you gain more confidence, you do more. Or you want to spend some time with somebody like Dr. Bashey or me, who's done a lot of these and who feels comfortable with them, and then you get a better idea of how to do these peels, and that's important. Understanding the depth signs is critical. Understanding the anatomy, the physiology is critical. Understanding when you need to stop is very important. Okay? So the first step is you're going to make your acid blue base mixture. That base is going to be decided upon what you're treating, how extensive you want the mixture to be, right? Dr. Bashey creates bases that vary from any concentration between 20 to 30%. I've seen him use anything in between. And when you get to a certain level of skill and dexterity, you're not fixated on the actual concentration of the acid. You're fixated more on the depth signs, right? You're not even fixated so much on the volume of the acid that you use. You're fixated more on the depth signs because that's what's going to take you to your ending point. Anyway, you create the acid concentration mixture, and then we start painting. We start painting the faces. And we start with several passes. A pass is different than a coat, okay? You need to be very clear that a pass is not a coat. A coat is the fixed volume in that jar or that glass jar of the total amount of the blue-based acid mixture that you make. So whether that's 4 ml, 6 ml, 8 ml, 10 ml, 12 ml, that total quantity is the coat. The passes or the layers are the number of times you will take the sponge that's provided and apply the acid over the face. So again, one coat might mean 4 passes. One coat might mean 3 passes. One coat might mean 8 passes. Just depends on how big the patient's face is and how you've made that coat, how much volume you've made that coat. That's important. So we start by painting the face, right? We just want to get a nice, light blue color with a red in the background. We keep painting and painting. We start, usually at the lower part of the face, and Dr. Bashey and I both perform this peel with sedation. I highly, highly, highly recommend sedation. And the sedation means IV anesthesia. This does not need to be done with general anesthesia. IV anesthesia is fine. However, it is not a very comfortable procedure when done with the patient awake, utilizing the Zimmer, or even a little bit of oral, like Ambien or a diazepam. So I learned this procedure from Dr. Bashey. He's always done it with sedation. I've done it with sedation. I sometimes use sedation with the nerve block, but I have never performed this procedure with a patient not sedated. And I've done several hundred of these. I can tell you that I have seen people perform it with patients not sedated, and it is a longer procedure, a higher complication risk, painful for your patient, and the peel cannot be taken to the necessary depth, okay? So we start clockwise, and I apply the acid with the sponge. Again, you don't want to take the acid over the person's face or eye. You want to make sure you have a flush available in case it gets in the eye. You want to go clockwise. You want to dip the sponge in acid, but not completely saturated. You want nothing dripping. Apply several passes or layers to the face to get an even look. Feather behind the ear, feather underneath the neck, an inch or two, and then you even want to take this up to the lid junction of the upper and lower eyelids. Now, when we reach the appropriate depth, we can check for epidermal sliding. So when we pull up the skin, for example, in this slide, we can see that we're sort of in the junction of the IRD and papillary dermis. We lost a lot of that epidermal slide in the form of the wrinkles, but we still see a little. So I can look at this and I can say, hey, look, I see a little bit of pink in the background. I have a little bit of epidermal slide, but not 100%. So I know I'm between papillary dermis and the immediate reticular dermis. Now, as I've done a couple more passes, I can see she's a little bit more blue. I've lost a lot of that redness. She's more kind of even blue at this point, so I know I'm at the IRD, okay? So the two signs that I have is I'm looking for that even blue, loss of the redness, and I'm looking for the loss of the epidermal slide. Now, if you look at her neck, or if you look at a portion of her chin, or you look at the area in the preauricular area, right in front of the tragus, you can see that over there it's a little bit lighter color, or if you look on her eyelids, you can see there's red. Those areas are papillary dermis, right? So you may go back and you may fine-tune this with a Q-tip. The eyelid should be papillary dermis always. The feathering into the neck should also be papillary dermis, always. Okay? So here, like I mentioned, we're going back with the Q-tip. We're just going in and just decreasing those areas where we see a little bit of that redness. We want to be very careful near the eye so we don't get the acid in the eye. And our goal is an even, nice frost. Okay? Now, here is an example where you see an area of epidermal sliding, right? You squeeze the skin, we can see the wrinkles in place, we can see the red in the background, we can see that clear epidermal slide indicating we're in the papillary dermis in that area, okay? And again, your peels, you're gonna wanna look because certain areas are not gonna have the same amount of, they're not gonna take the acid as fast as other areas, right? Some areas the skin is thicker, some areas the skin is more oily, and keep in mind, your patients are going to apply products not completely evenly. So you wanna be looking for everything. Here on the temple, we can see the epidermal slide. We see all those wrinkles. We see the red in the background. And then as we get into the, we walk towards more on the zygomatic bone, we see we've lost the epidermal slide and we've lost the pink in the background. So we are at the IRD. The IRD is the appropriate stop level for the majority of patients. However, the IRD is an area that I recommend you don't start peeling with. I recommend you start peeling to the papillary dermis first. Okay? So again, to give you a different perspective, papillary dermis, confluent color, however, pink in the background. IRD, confluent color, no pink in the background. URD, which is completely focal, will always be focal. Please remember that. Confluent color with a slight gray in the background. And this all has to do with the anatomy and physiology. Okay? What do we expect? In this particular patient, you'll notice post she had some pinpoint bleeding. We combined her controlled depth peel with some light laser resurfacing, and that's something you can do as you get more advanced. So again, the peeling is going to occur primarily day 3, day 4, and it's going to take approximately a full week. 5 to 7 days is what you should expect with a IRD level peel. Sometimes as long as 8 to 10 days. Papillary dermis usually 5 to 7 days, plus or minus. It just depends on how someone heals. Some people are going to heal faster. Some people are going to heal a little bit slower. During the post-operative period, while they're recovering, all protocols are suspended. Via DO, we have a specialized skincare protocol during the healing process, which can be used for chemical peels and also laser resurfacing. But we suspend the regular program and we primarily focus on the specialized aftercare during this process until the skin has fully epithelialized. Now again, we can get immense results with this procedure. Immense results. This is a middle-aged lady. She's of Mediterranean descent. And a very, very nice natural result. This lady, she was opposed to doing Botox. She was opposed to doing fillers. She didn't want to do anything like that. So, she just did a combined case here. We can get a lot of improvement. Same thing with this lady. We can create a lot of improvement. Notice the improvement in her scars. Notice the improvement in just, volume loss. that rebuilt matrix, that rebuilt hyaluronic acid, that improvement in her texture from a controlled depth peel. Same thing. Now, I want to point out something very interesting here, okay? In my opinion, this lady has very thin skin. You can see she has a lot of that submalar fat loss in that area. She's an exerciser. This is an area that, this is a type of peel that would be a more advanced level peel, right? Because you want to make sure you only take this controlled depth peel to the papillary dermis, which is what I did. We took her to the papillary dermis, went around her eye, went around the mouth. Massive improvement with just the controlled depth peel. Southeast Asian female with a history of very vigorous melasma and a history of even some hypopigmentation, uneven tone and PIH, oily skin, thicker skin. We took her peel to the IRD. We were able to create a lot of tightness, a lot of improvement. Now remember, there's no cure for melasma, okay? So when you're telling your patients about this, you're not going to tell them that this peel is going to cure their melasma, but what you're going to tell them is that, and this is what I tell them, this peel is a debulking procedure. It debulks the skin of that melasma so that subsequently the melasma is easier to control, okay? Caucasian female, medium thick skin, lots of sun damage, spent a lot of time outdoors. And again, look at the level of improvement in the texture, tone, sun damage. We've created a lot of thickness. And this is a lady, again, did not want fillers, did not want toxins, did not want anything. So we can create a lot of improvement with an aggressive skincare program and a controlled depth peel. This is a man of Hispanic heritage, mixed Hispanic and Middle Eastern heritage, so complex skin type, right? If we look at the forehead, we see oil, we see the acne, we see even a little bit of rosacea on the nose, oily skin type, very sebaceous, very thick skin. We perform an aggressive peel up to the IRD, get rid of a lot of that oil. He's improved a significant amount. I want you to call attention to his under eye. I want to call attention to the cheeks to see that level of improvement. Now, he's red because this picture was taken shortly after his procedure, and that redness goes away. We expect some redness to linger on after a chemical peel of any sort. Okay? Another female, again, sun damage, loss of volume, papillary dermal level blue peel, controlled depth peel, improves a lot. She improves a lot. Now again, this is a procedure where I don't need to take this down deeper than the IRD, right? I can get away with the papillary dermal procedure, which is what I did for her, and we see massive improvement here, okay? Same thing, we see a Caucasian female, we can see the sunspots, we can see the sun damage, the lack of volume, the fine lines and wrinkles, the under eye, look how hollow it is in under 4 picture, IRD level controlled depth peel, around the eyes, papillary dermal level peel, we see massive improvement, okay? The point is that this procedure can create a lot of natural looking results, right? Let's look at this gentleman. This gentleman is a pilot, Caucasian male, lots of sun damage, lots of wrinkles, fine lines, very thick, oily skin, rosacea on the nose. All of it improves with an IRD level peel. He's the kind of gentleman that you're going to need more acid on him. You're going to need several passes. You may need an additional coat and a half, up to 2 coats, right? Because of how thick his skin is. Female, Middle Eastern descent, uneven tone, oily skin, thick on the thicker side. Again, lots of improvement with just one procedure and an aggressive skincare program. This is one of my favorites. This patient, Southeast Asian descent, very bad melasma, uneven tone, PIH, very oily skin, thick skin. This would be an example of a patient that's very difficult to treat. How do you treat this patient, right? We went aggressive with her with the skincare. We performed one IRD level depth peel. We created massive, massive improvement in her skin, okay? And again, that erythema is going to resolve. This lady is so happy. So for someone like this, you can create a major, major change in her life just by performing one single procedure like this, okay? Now, how do you evaluate results? Remember, the process of forming collagen, the process of improving those glycosaminoglycans, and the process of cellular repair is not something that occurs immediately. It's usually something that occurs several months after. So I tell patients for a papillary dermal level peel, count on looking at the results 2 months later. For an IRD level peel, we should be looking at the results 3 to sometimes 4 months afterwards, okay? And again, your results, with this procedure, the results are fairly standardized because we've made the procedure safe and very standardized, right? However, your improvement is going to be based on how deep you go. The deeper you go, the more downtime, the more improvement. It's going to be based on how well your skin, the patient's skin is prepped. It's going to be how well the aftercare is done. There's a lot of variables, right? How well someone is healed, how well they take care of themselves, how much common sense they exercise in the post-operative period. So you can perform and prep someone really well, but the healing and their improvement is largely dependent on the patient. That's why it's important to screen patients really, really well for this procedure. It's really important. That concludes our presentation. And I would just want to review a few key concepts. Again, we have 3 separate potential peels that we have, one being an at-home peel, 2 being a physician or provider or nurse practitioner or a PA performed peel. And the peels can be used for all different things. They're very versatile, they're very safe, they're very effective. I would encourage you to learn the anatomy and physiology of the skin, spend time with people who have done several peels so you can learn how to do them correctly. I think that makes a big, big difference. Once again, thank you so much for your time. I really appreciate this. My name is Dr. Bashey. I'm a board-certified dermatologist, and I appreciate your attention. Please message us or reach out to us if you have any questions.